Yeah, so I'll direct the questions. Go ahead.
Hi, I'm Sahar from Manitoba. So one of my questions is the thoracic surgeon that was suturing the diaphragm. She used staples instead of stitches. Do you have any preference what to use in endometriosis surgery in general? And can we use also staples when we close the vault if we are doing laparoscopic hysterectomy? So that's my first question. And what's your preference, the V-lock versus stratific suture, if any of you have any experience about it?
Thanks for the question. So it was a thoracic surgeon, obviously not me, that was working in the chest cavity. So they do a lot of stapling on the diaphragm, which is reasonable. And Annie and I were watching and saying, oh, it would be so nice if we could just do that. The general surgeons obviously use it on the bowel, but we generally don't use it on the vaginal cuff because the staples obviously aren't dissolvable, and so you could have I don't know of any studies, maybe some of my colleagues know, but yeah, some either dehiscence and or dyspareunia from those staples at the top. So I generally suture that with the diaphragm. It's really up to the thoracic surgeon if they're going to staple or suture. In that case, we actually did a combined case on her right hemidiaphragm where she left the hole open because it was low enough and adherent, like sort of adherent to the liver. So she felt it didn't need to even be closed. So definitely consult your, colleague. I would not make that decision myself. And with respect to the barbed suture, it doesn't matter if you use barbed or which type of barbed, non-barbed. It's just different, techniques and whatever you feel most comfortable with. So I either use interrupted sutures or V-lock, but that's just a personal preference.
My second question is about the psychological treatment. What other strategy do you use with a patient with the chronic pelvic pain other than coming and interviewing the patient, having the couple to ventilate, and then what is the next step?
Sorry, so thank you for the question. If I understand correctly, so what type of interventions do we use? So there's some good evidence for cognitive behavioral, like a regimen of cognitive behavioral therapy. We can incorporate elements of mindfulness, our acceptance and commitment therapy act. So it is with couples, so we haven't developed the full protocol, how we would do this for endometriosis. But for couples with other types of genital pelvic pain, usually what we've done is a course of 12 weeks, bringing them in, and we focus on treatment goals that are related to the relationship, pain management, and also their sexuality as well. So does that answer your question?
Oh, yes.
Okay,
Yeah.
good.
Yeah. My last thing is a comment about, in general, the underestimation of women's pain, which is seen. In fact, there is a lot of studies and statistics about it, that always the woman, when come to the ER with pain, somehow as a health provider, we may underestimate it or not take it seriously as we take the male pain. It's somehow a gender inequality, which is, of course, it's not acceptable. And I was shocked to know that one of the women who came with chest pain and was sent home with some pain medication and then died at home with heart attack. Yeah.
It's very sad, and I know that was really interesting to hear about too. I actually lost track of one of our research participants for a few weeks, and when I found her again to do our interview, I said, "What happened to you? Where have you been?" And she said, "Oh, I ended up in the ER and had to get my appendix removed." And she had gone in 3 times, and she'd been sent home all those, 2 times. The 3rd time her appendix had ruptured. And she kept getting dismissed because in her, and this is interesting, in her chart, it was indicated that she had endometriosis. And so she was sent home because they were attributing her pain to another condition and weren't looking for something else. So it's very common.
I
He wants me at the podium, I don't know. I literally saw a patient this week in clinic who was an endometriosis patient of mine. I had discharged her because she was actually doing quite well. She had gone to an emergency room the week before with an acute flare of pain and was sent home. And I knew something was weird about when I saw her in the clinic, so I scanned her and she had torsion. And I looked back at the pictures from the week before, and torsion was on the pictures the week before, but now the ovary was 4 times the size, completely necrotic. And I had to tell her that her ovary was dead because nobody recognized it. And so, endometriosis, we have to recognize women's pain for sure, but we also have to not be narrow-minded. Endo is not always the cause of people's pain, and we have to think outside the box sometimes. Sad.
So I have a comment on here as well. This is more of a reflection, a great comment, that one of the things for the panel, and I guess we all focus on endometriosis, is that I would love your feedback too, that we could probably have offered more clear tips to take home from the psychology, from the clinical, from the academic, and I think that's important because not all of you have access to some of the things we have access to. So I appreciate that person who put that up, that we really would benefit. And so hopefully we gave you some tips, but I think if we were to do it again or in sections, we could say for medical management, this is a case, and so this is the beginning, it's the first one, so I really do appreciate that feedback and would love to hear from others when you please do your evaluation as well. Go ahead.
Hi, Jenna McNaught from Winnipeg. I'm a pediatric and adolescent gynecologist, so I'm usually on the receiving end of these new consults for teenagers with really bad dysmenorrhea. Often their mother and their sister has endometriosis, so I'm seeing them. And I'm also the one giving them the diagnosis of, well, this could be endometriosis, but we don't really do surgery right away now. We treat it medically. And, even if I knew you had endometriosis, we'd do this, this, and this. Like, this is the treatments we do. But I still get some resistance to hormonal treatment, which I don't really understand what they expected me to do. Like I have a magic wand to make their pain better without hormones? I don't know. So I just wondered if there was any evidence that treating it early prevented progression and worse disease, and that I could use that to kind of make people consider medical management.
I can answer that. There's some evidence that that untreated pain leads to wind-up of the nervous system. So dysmenorrhea is a predictor of central sensitization, severe dysmenorrhea. Now, is it the chicken or the egg? It's hard to know, right? Are people experiencing more severe dysmenorrhea because they have a predisposition for experiencing pain in a stronger way? Or is it because they've had untreated dysmenorrhea that they have all these peripheral, like they do, they do pain sensitivity testing in the arm and the hand, and they have a lower pain threshold, higher pain sensitivity. So it's hard to know, but certainly treating pain early is important. So that's the biggest argument I would say. With respect to, the question came up with respect to fertility. I don't know that we know that it's necessarily going to protect, but if they have developed endometriomas, deep endo, that kind of stuff, you certainly want to prevent the progression and increasing size in endometriomas. I'm curious to hear what my colleagues think about the fertility context and progression of disease.
I don't think that there's evidence that says for sure it will preserve fertility because we don't have good evidence, like those studies don't exist. There's some evidence that it will protect against recurrence of endometriomas, so I'm very careful with those patients. But I think I always talk about that as like theoretically it causes inflammation, it causes scarring. So if we treat it early, and I talk about the pathophysiology and the theories of how it forms, and so that theoretically if we stop menstruation, there's not progression of the disease, and therefore it may help your fertility down the road, because I don't think that's wrong to say at this point.
I think it's very important to reinforce a message that pain from menstruation, where you have to take days off of school, where you cannot have your normal quality of life, that is not normal. So whether there is endometriosis or not, it needs to be treated. That's something I find very helpful to reinforce that. In terms of progression of endometriosis or suppression, it's really hard to do those studies without second look laparoscopies and such, which are have their own issues as well. But as Catherine was saying, menstrual pain is a pain contributor in and of itself, and if this is occurring every month, this person could develop chronic pain if it's untreated. The other thing I wanted to mention, more to do with psychologic therapies, is it's not within our scope to provide psychologic counseling, but there's a lot we can do to help patients understand the role of their psychologic health on their pain. So I really liked what was mentioned about the reason for seeing psychology, which is to support patients in coping with pain. And I think that will often be validating that of their suffering. I also think it's helpful for patients to understand that their perception of pain is modulated by their psychologic state. So one thing I tell patients often is, when we are anxious and fearful, especially when we're fearful, when we're stressed, we feel more pain. And when we're calm, happy, relaxed, then the pain is decreased. And even though the pain is, arising from the pain signals coming from your pelvis, what happens in your brain can modulate that. So that's why we recommend sleep and mindfulness and yoga and all of these things that can be good for our patients.
So I just wanted to comment on the adolescents for a second, because Lisa Allen and I have started to work together in this domain. We now have access to a mini ultrasound probe, which is as small as a finger, and we have been able to scan patients as young as 12 years old, potentially younger, but that's the youngest thus far that we've scanned transvaginally. We also readily offer transrectal ultrasound in these adolescent patients. And part of the reason why I'm so motivated to push forward to do this investigation in them is because of that question of, what do I have? They often want to know what they have before they commit to a treatment. And I personally find, this is still anecdotal, but we are working on this from an evidence-based perspective, is the ability to commit to a treatment for a disease that is a chronic and incurable disease, that, a 16-year-old who doesn't want contraception doesn't really want to be on a hormonal pill. They're already going through enough with mood. So if they know that they have a disease that is a chronic disease that could lead to fertility issues, could lead to chronic pain, but they know they have it, my theory is that they would be more willing to take that treatment. So I really think we need to offer young women the option of a scan, even if they're virginal, whether that's transrectal or transvaginal, and again, give control, give autonomy, not apply these rules that you can't do a scan in a virgin, because they deserve as much autonomy in their diagnostic journey as they do in their therapeutic journey.
But Matthew, can I ask a question?
Yeah.
In that patient population, what do you think the actual incidence of detectable deep or endometriomas is going to be? It's going to be extremely low. So you're not going to add much. You can't rule out endometriosis with that.
So this is a very good point, and I
Yeah.
totally agree. In fact, most of these patients will have superficial endometriosis, which sometimes we can rule in, and it does help them commit to that treatment when we can rule it in. When we can't rule it in, what we can do is we can reassure them that their overall pelvic architecture, their uterus, their ovaries, their tubes, their bowel, their bladder, their ureters are normal. And this carries a value, because again, it comes back to that concept of a map. What these people feel, and I'm extrapolating here because I don't have periods and I don't know what it feels like, but I can imagine it feels like a bomb has gone off, and they go to these worst case scenario places that danger is happening. That's what the nervous system is telling them in these moments. So if we can validate their pain, if we can offer empiric treatments, but also reassure them that nothing dangerous is happening in this moment, that might allow for the nervous system to somewhat settle in a way that we can attend to some of those central sensitization mechanisms, but also get them to commit to medical treatments, which we know they need, but at baseline, most of them don't actually really want. Does that I don't know. Does that theory kind of align with your thoughts? I know,
Well, I mean, I hear what you're saying. I think you and I can have a long debate on this, so
Yes.
we're not gonna, I'm
And we
gonna
have
keep
over the
it
years so
short.
far.
I think Annie's point of treating the pain is the most important one, and if these patients are seeing you, they obviously are in pain, they have severe dysmenorrhea, and so whether there's endo there or not, you're gonna treat it the same way. That's my argument. I was like, whether you have peritoneal endo or you have primary dysmenorrhea, you have severe pain that's impacting your quality of life. We need to treat this. And surgery, unfortunately, is not a cure. So why would we do something that's invasive and not going to provide a cure? That's why I take that approach.
That's my opinion as
Yeah.
well, but
Yeah.
the 15-year-old in front of me disagrees with that.
I was gonna
I
say,
had,
so
I had one recently, sorry, that was so afraid of side effects, and she'd never tried even a OCP. She was so afraid of side effects. She said, I'd rather be in so much pain that I have to go to the ER every month to get IV medications than to feel like crap all the time. And I'm like, how do you know you'll feel like crap? You've never even tried it. So.
Yeah, I mean, in that respect, with the side effects, I hear that all the time. And I always say it's good that I have a long wait list, because I always use that to say, well, we'll just put you on my wait list. And then if you have pain and none of the medications work, then you're in line. You're not behind the line. And it's 12 to 18 months. So in the meantime, do you want to try something? And I say this, I think that they have a big fear. Sometimes it's just a lack of education, where they think that they're going to get side effects that will be persistent, or that there's side effects that can really harm them in some way that's long lasting. So I also explain that the medications have a very short half-life, which means it's out of your system. You'll feel back to yourself in a day or two. So there's no harm in trying, and if it doesn't work, you can stop it, you feel better. So I think just taking that time to counsel and educate helps a lot. With respect to the debate going on, I feel that I was like Catherine and not a believer for a while, and I felt the same, like, even if you have endo or you don't have endo, I don't understand, just try the medication, because either way, you have pain, you have dysmenorrhea, take the medication, you'll feel better. And there are a lot of patients that it is very validating, and they really want to know if they have the condition or not, and they will buy into the treatment a lot better. And so now Matthew's made me more of a believer in that. I do agree that it depends on the patient. So for the vast majority, if you counsel them that, you know, it doesn't make a difference, management is the same, they will accept that and move forward. But then there are some that I think if we can offer them imaging for validation, and diagnosis is much better than a surgery, which has much greater risks, and we all know that it's not going to be a permanent solution. So I do see the benefit.
I do want to make sure we keep going with our comments and questions.
You don't want to keep the debate going?
No, but I will say one thing, that, because I got to be the moderator, I get to make one comment. I do think that I am a little bit worried that we do end up getting caught in our old rhetoric, and I do think that this is less about us, and it is about the patients. So what I try to do, and I was taught this a long time ago in my residency, is you may have those feelings where the patient, you know, you've recommended things, they don't want to take it or anything else, but I always want to be there for them, and I tell them it's a long-term journey. So I think everybody up here, everybody out there, regardless of what the patient chooses, as long as you've laid it out, you're there to support them. And I think that's the part that I hear, the validation and the
Can I just
support.
clarify? I've never taken surgery off the table in my adult patients. I think the potential for harm is higher in teenagers. That's why I said that, because the stats are clear. The earlier the first surgery, the worse patients are more likely repeated surgeries. That's why this patient population, I'm very concerned with laparoscopy.
Perfect.
In my patients, is never off the table.
Yeah.
No.
Okay, do you want to make I was trying to close the conversation here. Want to make one last comment? Yeah.
One last, so in my discipline, I often, when I'm teaching clinical students, and I was talking about this with Elisa earlier today, is a diagnosis has a utility, right? And has an important utility, but it's not the only piece of information we want, especially not in psychology. We want to have a whole conceptualization and understanding of that person. And so sometimes in the absence of a definitive diagnosis, or if we have something of a differential, we can still offer an explanation about what the consequences of that pain is doing to their lives, and talk to them on that level of, a full conceptualization of their experience. Anyway, so I don't know if that helps.
No, I'm gonna let our question asker was holding a while here. It's gonna go Jan.
Hi, I'm Jeff from Vancouver Island. I was in the wagons with Catherine going out west, my fellow pioneer. First of all, I wanted to remind Dr. Singh there was 3 wonderful questions asked just before the break, before the lunch break. I hope you recorded them because they were great questions, which I've forgotten, but I was really looking forward to hearing the answers. But my question was all about cystic adenomatoid malformation as it relates to adolescent patients and just your thoughts around how we can best diagnose and manage that condition.
I think you mean ACUM, is that what you mean? Accessory, yeah, that's one thing we haven't talked about. I'll let maybe Matthew, the ultrasonographer expert, but I think that's one thing that I've seen a lot more in my practice totally being missed, and I'm curious to see what you say about
Yeah, there's
that.
a little bit of growing literature around the accessory cavitated uterine malformations, which is the more, let's call it modern name for juvenile adenomyosis or cystic adenomyosis. It's still a rare entity, but it's becoming a relatively recognizable because it's pathognomonic. It's in the lateral myometrium under the cornua, appears like a endometrioma but within the muscle. As a surgeon and as a focal pathology, I actually think this is something that we can tackle surgically, one form of an adenomyosis that is surgically tackleable once it's diagnosed, but also it doesn't need to be. I mean, if patients respond well to medical therapy, great, that's also fine. It's something that can be monitored. I don't know if anybody else has any other thoughts on that.
Yeah, I think the big red flag is if you see a single fibroid in an 18-year-old. It's unusual for 18-year-olds to have fibroids. It's not a common thing unless maybe they're African descent or a black background. But I had patients like that where the fibroid was consistently like seen since they were 18. They see me at 24, debilitating dysmenorrhea, not responsive to hormones, and I scan them and I'm like, this is not a fibroid. This got fluid inside, and I remove it and they're cured. It's the most satisfying diagnosis, I have to say. I'm sure we've all seen it.
So what we'll do is we will come back because Julie, who asked that question, has written like a whole essay online to make sure. So can we go ahead with one more question in person and then we'll answer her questions.
Hi, everyone. My name is Karen Parmar. I'm actually a naturopathic physician from BC. I do primary care in reproductive health in BC. Our scope of practice is much larger than in Ontario, and I do IUD insertions and medical abortions. I use PCOS in my practice for both of those skills. I see a lot of the fertility docs in fertility clinics using BCL6 as a marker for endo, and I wonder if anyone could comment on your thoughts on that.
So, well, so biomarkers is what you're talking about.
Yeah, it's an endometrial biopsy, and it's an
Oh, so you're
inflammatory
talking about the
marker
endometrial marker.
that's used, they're using in the fertility
Yeah.
clinics before they do an
That-
IVF. and
It was
just
from
wanna-
Yale, I believe. That's the Yale test.
Yes.
Yeah, so at the end of the day, just in general in biomarkers, we still go back to the guidelines where we couldn't comment on any specific one. We reviewed it all. So there's the endometrial biopsy one, which has been around for a long time. And then there's also the blood testing in the panel now as well. And so Matthew and I don't know if any other center, I think Catherine Center is involved in a large Canadian-wide evaluation of this panel, which makes more sense. I guess when we go back to why we want to diagnose it, I'll just give my 2 cents, is that at the end of the day, with good history, physical and imaging, I think we've got a huge potential for making that diagnosis already, where I see these things coming in, and especially in the infertility, let's talk about that first, is they used to all go to laparoscopy because they used to change their protocol and how they managed patients. So I think they wanted some insight in doing this test in order to guide their therapy or treatment. I know Catherine can talk about that. And then the second part is patients who are at a loss across the country, who have no access to anybody, are frustrated, can now pay for a test and then be able to arm themselves with that dismissal. So I think those are the 2 ways I see it. By the time you see people who have a lot of experience, I think we're on the track of getting them the diagnosis. I think it's helping some of those folks. Before I go to Matthew with his comments, because he's worked a lot on it, Catherine, that's how I see it for fertility patients, because I used to do a lot of infertility, that the test would be there to help guide perhaps potential changes in the protocols, right?
I haven't been in the IVF world in about 10 years now, so I haven't seen them do much change other than now that the embryo transfer part. So now that they're freeze-all cycles, it's making it a lot easier to pre-treat or suppress prior to embryo transfer, which is probably a good thing to do if you have documented endo, or certainly advanced endometriosis, to do like a 3-month Lupron, or at least, and they don't go to Lupron often, they use progestins or birth control pill, which I think is kind of half-assed. But anyway, in the past, they wouldn't do it at all because they're worried about ovarian responsiveness and stuff. So that's changed the landscape, at least the patients are getting that suppression. But I still see a lot of missed endo, a lot of straight to IVF, and people that could have potentially, done better with, or had some options, that are not offered because the motivation isn't there to offer alternatives when they're at an IVF clinic, right? So.
I'm making,
Yeah, standing up a
Him
lot.
get up
My watch
because-
is
Getting
happening.
your exercise, please.
So I see the biomarkers, broadly speaking, not specific to BCL6, as a tool to help in the cases of negative imaging. So I do think every single person who presents with pelvic pain warrants advanced ultrasound to assess for adenofibroids, polyps, PCOS, endometriosis, adhesions, really the gamut of pelvic pathologies that can cause those symptoms, plus also fertility. And in the absence of any pathologies, these patients could have endometriosis still that's not visible. And those patients, one, want an answer, and potentially it will impact on their clinical decision-making in the context of fertility or maybe surgical planning management. So that's where the biomarkers, I think, will fit best. But as Sony said, I think in rural centers, it might act as a triage tool to get to a tertiary center as well. And I don't know which biomarker will win this biomarker race. There's the saliva test out of France, the Zwick test, there's the Endomere test that we're doing a cross-country study on, a validation study. There's the BCL6 Receptiva test. There's all these different ones. Which one will win? I don't know. Maybe they'll have different pros and cons as we learn more about them, and different populations might be better served by certain ones. Like in the rural centers, an endometrial biopsy is not going to be so viable, but a saliva test, that one might be. So it's a good question.
Okay, thank you.
we have a lot of questions for you afterwards to help guide us as to your practice, because we don't understand it. There was a couple of things we missed. We missed naturopath and treatments. There's bowel. There's so much more we haven't covered. And fertility, unless I'm totally off, we really didn't get into fertility. And Mohammed Badawi is not here, but he would definitely. So in the future, we could do that. Okay, so here's the questions for the panel that were missed earlier. So actually, she didn't write all the questions. She just wrote an essay to me. But a couple of things that we did have here was, let me try to remember them as well. Oh, let's start with the dietary changes. So what do you recommend as a panel? And I'll do it more systematically so that we don't, we have a bit more organized. We'll start with Jamie. When people come to you, what are you recommending for diet? And then I'll ask our naturopath colleague to also comment. So go ahead.
So there's a lot of different options that are out there that people suggest. I always tell my patients that there's no evidence-based research that I know about to suggest that one diet is better than another, that there's documented evidence that diet versus no diet makes any difference. So I tell patients it's not going to be harmful. So if they can try it, the person that taught me believed very strongly in a macrobiotic or an anti-inflammatory diet. So I have some information to provide patients based on that, but I tell them again that it's not evidence-based.
So on our website, we have a dietary handout that we created with the help of a nutritionist in our hospital. Probably needs to be updated because there's always new evidence coming out. Basically, it's very symptom targeted. So if there's a lot, and what I tell patients is no evidence that diet will change the progression or cause a regression or affect the lesions of endometriosis, but it definitely can help with symptoms. So it's a symptomatic treatment. So if and then the one diet that has evidence now is for irritable bowel syndrome. Low FODMAP does have some evidence for it. So that is the one that has some evidence. And when they do endometriosis studies, that's the one that seems to help because I believe it helps with the bowel symptoms that we see with endo. So we have targeted ones for painful bladder, irritable bowel. And if they don't have that specific symptom complex, then usually we recommend a low inflammation diet, again, based on very little but it's usually a healthy diet anyway, like it's, you know, it's for long-term longevity and all that, so.
Yeah, I also recommend like a low FODMAP diet. I had a couple patients come back actually with like really good feedback. It mostly came from them rather than me telling them to do it. They just told me that they ended up doing it and they had great results. So I've decided I'm going to learn more.
I think that dietary recommendations can be made based on their symptom profile. If they have symptoms of IBS, then a low FODMAP diet might be the diet to try first. Often if they have painful bladder symptoms, then if you go to the website ichelp.org, there's a whole list of dietary potential irritants for the bladder. Now, most people, now that the list is very, very long, so, if people cut out everything, they pretty much can't eat anything, but most people will be able to identify one or two bladder irritants from that list, going through a kind of a more rigorous elimination process. A lot of patients will tell me themselves that they tried cutting out gluten and it actually helped them. Then we just take it and we run with it. Same thing with milk products, but really the low FODMAPs diet, painful bladder diet, and anti-inflammatory, those are the ones I mentioned.
Serena doesn't want to talk about diet. Go ahead.
No, speaking of evidence-based diet, I went to there's aspects of the Mediterranean diet that help with mood, and if that's helpful in the context of what people are facing, and immunofunction too.
So one of the things, as I hear the answers, I think one of the things that reason I do partner with a naturopath as well, mainly for the dietary side, not a little plug there, is that we're not as clear, that everybody's kind of got this area. So I spent more time, I just did a webinar for a US organization on GI symptoms and endometriosis. And what I learned in approaching myself is we need to be a bit more clear. So I do set out the 3 evidence-based ones. So FODMAP, again, symptomatology, Mediterranean, anti-inflammatory. But then I give them the resources of how to follow those. But I always end with, you have to do the research, you have to do the work on your own, and you have to work with you can do it on your own or you work with somebody. So in Ontario, you can get a dietitian by phone if you call telehealth. I don't know if you all knew that. So if you call telehealth, you can actually get a dietitian on the other side, give you general recommendations, generally for weight loss and everything else. And then the second thing is working with, in our community, it's a naturopath that we mainly end up working with. Her name's Jessie Pierce, and she's been great.
Can I reach this mic? Yeah, now I'm coming into something to say. We're doing an RCT right now on the Mediterranean diet, actually, and that's the one that, based on our literature review and working with an academic registered dietitian out of Australia, seemed to have the most optimism. So we're maybe about halfway through recruiting for that. It's a small RCT for now, hopefully going to build that and then do something more multi-center thereafter. But in my day-to-day clinical practice, I actually don't really make strong recommendations myself. I actually encourage the interdisciplinary approach. So we have a few registered dietitians that we've connected with across the country. They're actually listed on my website that have evidence-based approaches to endometriosis and other pelvic health issues like PCOS and fertility. And so I usually say, there is growing evidence in this space, and anecdotally, we've all had patients who have had significant improvements in their symptoms. I recommend you take that individualized approach with an expert who can counsel you. And here are the list of people that I've sort of anecdotally vetted over the few years, and that list is growing. So if anybody has people to add to this list, or maybe we want an SOGC or CanSage list, that would be great for people to use.
Whenever we start talking about diet recommendations, I'm always conscious of socioeconomic circumstances for the patient and also functionality. So following a medical regimen, following a dietary regimen requires resources, psychological resources that not all of our patients have. And so sometimes when I hear of colleagues making some choice, like, okay, well, do we know that they have the organizational capacity to follow this diet? A lot of our research participants talked about how they didn't have enough money to follow certain diets. And so it's something, food insecurity.
Can I just, another thing you probably wanted to is eating disorders. So some patients have a history of eating disorders, and that's where restrictive diets are quite dangerous. So you really don't want to get into that without them seeing a dietitian, right?
So the other two things, telling people to eat more fiber, that's not good. I tell them often their abdomens or their gut is like they're brewing beer sometimes, just load up the fiber and they get more and more bloated. And then the other thing is the cost. So I talk about this with our naturopath colleagues, if I'm referring them, if it costs a lot of money, it probably won't work. And if it kills you, don't use it. With that note, I don't know if you want to add anything afterwards, but go ahead, we'll go to the next question and I'll go back to the medical question.
Hi, my name is Dr. Reiches. I'm coming from Montreal. I'm a urogyne. And I'm just wondering, how do you diagnose the centralization of pain and how does it change your management and how do you treat that?
Do you want to go ahead?
Want me to take that?
Yeah, and then I can.
It's a very good question, one that we've struggled a lot with because currently there's no absolute criteria for central sensitization diagnosis. There's some associated features in chronic pelvic pain that correlate with high scores of CSI, et cetera. So one that we found is abdominal wall pain and the other one pelvic floor muscle tenderness. But then there's also the questionnaire, the CSI questionnaire, which seems to be fairly discriminatory in terms of predicting, for example, poor outcomes with surgery. So that indicates that basically in the clinical practice, it's a gestalt of some sort. It's like the patient, has a huge impact of their pain on their quality of life. They have multifocal pain. So when you examine them, they have, abdominal pain, pelvic floor tenderness, bladder-based tenderness, there's vestibulodynia. There's multiple pains and there's comorbidities, overlapping conditions usually. So IBS, PBS, pelvic floor muscle tenderness, anxiety, depression, all, when you do questionnaires, they score positive on many things. So those are the types of things that make you think, okay, there's more going on here. But in terms of an absolute, one criteria, I think that there's still evolution in terms of what would be a categorical yes, no. It's of diagnosing central sensitization.
So the way I simplified it, and I remember writing the first chapter to a book on how to diagnose endometriosis, was if you go back to history and they tell you that they had painful periods all their lives, and then you hear that transition to suddenly I've got pain every single day. That to me is starting to really show you the progression of that pain, and that's where we use our own scripts, such as the alarm system, which is pain is there every month with your period, but then it's always on. That progression is very important. Someone who comes to you and says, I've got full body, or I've got pain all over my abdomen, it started yesterday, right? That's the torsion. That's very different than years and years of pain with my periods. Now I've got pain every single day over my whole body. There's a whole picture that starts to evolve. I don't think it's, even though we may not have a research diagnosis, it is that bigger picture and unraveling it. I must say in my medical management, Julie wanted more tips. We have a sheet on that omig.ca website. HCP, all capitals, 2024 it's a space, HCP space 2024. We've got a little worksheet we do, and there's so many options. And I love my amitriptyline. I love helping with sleep and constipation. These are strange things for gynecologists to like, but it makes such a huge difference to get their quality of life up and going. Ligalix, 200 milligrams once a day was Julie's other question. Do you use it? Because right now it's 150 once a day, 200 BID, but some patients are moving to once a day, is what the question was.
I think I think the reason they do that is because cost, right? So if you get prescribed 200 BID, it's the same cost as the 150 once a day, which is kind of silly. So if there's a cost barrier, if you prescribe 200 BID, they'll cost whatever, $450 a month. But if they, instead of the 150 a day, they can take one of the two pills, so it winds up costing them half the amount. And the difference, is marginal, except I would not anticipate that they would be fully suppressed, so.
I think it's a safe dosage based on, our knowledge. And I do think that's why they're tapering down, but also because of side effects as well. So Ligalix on its own, in my mind, is not an ideal long-term treatment strategy because of effects on bone mineral density and other long-term effects of hypoestrogen. However, it can be a very good strategy for very rapid menstrual suppression and it kind of avoids that period of 3 to 6 months of transition where the bleeding can be very irregular and distressing for the patient. So one approach is to start with Elagalix 200 BID, and then once patients are menstrually suppressed, we have a discussion about potentially tapering to something we can use more long-term, like Dynagest or even levonorgestrel IUD.
I still like the 150 once a day of Elagalix. I feel like I'm like a lone wolf. I find that for some patients, and I was just saying to Catherine, I'm not sure if there's a difference in pricing, but my impression is that it's less expensive in Ontario, the 150 once a day, than the 200 BID, but I may be wrong. Don't quote me on that, but I'm gonna now have to look into it because I've never had any patient use the 200 once a day. I feel comfortable using the 150 once a day long-term. It would be off-label to use it greater than 2 years, but I just recommend bone mineral density testing after 2 years if they're going to extend it. I think theoretically their estrogen is kept in a reasonable range, and for some patients, I just find that they do have significant side effects on combined hormonal contraceptive or Dynagest, and because using the GnRH antagonist, they, for whatever reason, may do better. It's a different medication. I always call it quote unquote non-hormonal because it itself is not a hormone, and some of my colleagues say it's semantics. However, I think that some patients just like taking something that is technically not a hormone, but just lowers their own circulating estrogen. So I still do use that, and I find that I'm just happy that we have such a large number of medications in our armamentarium now, and I've had a number of people that do really well on it that don't respond well to hormonal treatment. I also really like my Fembry that's come out, Relugolix combination therapy. I find that's working also very well for patients to have that complete suppression with the add-back all built in as the once a day.
So last couple of questions. Anybody else on the floor as I prepare for that? So drospirenone continuously was the other question, which I think the brand name, we're not supposed to use brand name, but it would be whatever these folks have said. So yeah, I've been using it continuously. I don't see an issue with it as well. I haven't had enough of an impression, but it sounds like you would use it continuously as well.
In terms of progestogens, and not specifically drospirenone, but any medical suppression, the evidence for continuous use is better than cyclical use.
Can I just make a comment that there's still people using prometrium to try to suppress patients because it's natural and people are more accepting of it, but it does not, you'd have to use like 800, 1,000 milligrams a day to suppress ovulation, so that is a false, or it's not a useful treatment, and at that dose, people will be sleeping all day. So prometrium is not suppressive, but I still see people trying to prescribe it, so.
So avoid prometrium.
And I would say, I think you do get better bleeding control with Slind compared to Micronor. And so for those that technically want a Health Canada approved contraception, I think it's a good alternative. Drospirenone. Sorry. And whereas Dynagest, is technically not a contraceptive, but I tell patients it's, in Europe used as a contraceptive, and if they're not menstruating, they're probably not ovulating, but they can't hold me to that.
So one of the other things I've really been doing a lot is when people have side effects to mostly everything, including Dynagest, we use northindrone acetate, but at half a pill. So in Europe, 2.5 milligrams is what people use, and I've had really good success. They have a lot less side effects, but here the starting dose is typically 5, so try 2.5, and the patient who is having side effects will start at a small dose, cut the pill in half, and try to work them up that way. Question over there?
About back to the teenagers. Do we know when endometriosis is first present, or if you're at any point past menarche, can you have endometriosis? If we're trying to tell people the odds are because you're 14, 16,
So this
24.
is, the reason you might see some of us smiling, it's a loaded question, and there are actually some folks online who are very passionate about this. We have patient advocates online because there is, I don't want to misspeak, but there are folks who really feel strongly that it is started at the embryo stage and that it gets ready at that point. And so that's why there is advocacy for early intervention, including radical surgical excision. So I think at the end of the day, that's just one thing to be aware of when you're with your patients, because they will come to you with information that is published by some of the folks who've been around for a long time. They're not in practice, but they continue to put out some of these theories, which is really confusing to understand. So if you ever do have somebody coming to you and say it starts at the embryo stage or in the infancy, don't think it's because they are just making it up. It's out there. So that's one answer you may see. I didn't want to complicate things, but that's why you might see Matthew and I smiling and others. But let's go back and maybe hear from some others as to if you have any other comments or questions before we answer.
I think we'll only know once we have a non-invasive test, honestly. That'll really change the game into figuring out like when the average age, I mean, the average of diagnosis is 31. It gets late, right? So, but that's a whole other issue. So I think, I don't know that we know the answer yet.
And I think it also just goes back to like what we've all hammered home, I think, about validating pain and patients' pain experience, and that, you know, whether it starts like at 14 or prepubescent or whenever, you know, there's probably some component that's progressive. And I think I personally think it starts very, very early. And to recognize that the amount of endometriosis doesn't correlate with symptoms. So I, you know, feel, again, like what we've all discussed, I feel very strongly about treating symptoms and from an early age. Yeah.
So the only other thing that I would like to add is that a couple of things. One is I have seen deep endometriosis, quite severe in very young patients. We published one of our papers, I think she was 15 or 16, with severe deep endometriosis, huge endometrioma. Having said that, most of my time, and I remember these cases very vividly because now 20 years later, they're 20 years older, right? Just like all of us, where that is where I've come into the hospital. They've been admitted 5 times. You sit down with them, you talk through with them. Their bowels are always an issue. I do end up having to do a scope at that time. The issue of the scope is that we're not radically excising all the peritoneum, which is what's been advocated by some folks and causes a lot of complications. But if they've been admitted 4 or 5 times, they really want us to look, they really want us to see. But that whole dialogue takes hours and hours. But I'm so grateful that we had that connection, because 20 years later, they've had their children, they've had a positive life. But that caring, and where's our pediatric gynecologist, is that connection early on is so important, that therapeutic relationship to show that you'll support them. But 99% of the time, I'm convinced that it's bowel, constipation, it's coping, it's validation, it's so much other stuff. And when I look at the cases, even the ones I found endometriosis, it's managing all of that other stuff at the same time. And I think that Catherine's worry is we do have colleagues who have advocated for complete peritoneal stripping at the age of 13, 14 when they come in, severe complications, severe issues, without addressing all those other things. So
But there's probably like multiple different phenotypes, which we all recognize too, you know, between superficial endometrioma formers and deep endometriosis, and there's probably different causes of each of those different phenotypes. But there has been evidence in the literature of prepubescent girls that even have been diagnosed with endometriosis, probably from coelomic metaplasia. So I think we're like just at the beginning of really understanding that more.
Great, thank you.
So, one last question, I think.
Hi, I'm Dr. Juana Pisha, Gynecology Oncology Fellow. Thank you for a great panel. But I have a question. I know the risk of malignancy in endometriosis is not so much, it's rare. But we have seen patients that had endometriosis, chronic endometriosis, and came with malignancy that was diagnosed, for example, 10 years after first diagnosis. How often do you prefer the ultrasound for diagnosis of malignancy?
Matthew's going to stand up and go to the last visit up.
Thanks. So for those that don't pursue a surgical management and have an endometrioma it does require ongoing monitoring. Right now, the group in the world that's leading the way in terms of evaluating ovarian cystic lesions is IOTA, the International Ovarian Tumor Analysis, and they will soon be publishing some long-term data on like 5 years observation of various ovarian masses, which might give us some sense of, do we need to watch for 5 years, at least within those 5 years? But because of the association with clear cell and endometrioid in the context of endometriosis, likely we need to be watching these annually, at least, into the postmenopausal years. So that's kind of the recommendation at this point, because we don't have evidence to say we can stop watching these in those women.
Okay, so to sum up, is annually until going to menopause,
No, even after.
even after?
Even after.
Okay, thank you
Yeah.
so much. Thank you.
So because of time, we do have to wrap up. I just have a couple of summary things that have been brought up in the chat as well. Number one was the comment of interdisciplinary care was brought up. What does it mean? What I can tell you what it doesn't mean is that you call in a general surgeon, but you yourself don't have a lot of experience with endometriosis. It truly does take an endometriosis expert to manage these really complicated cases. To bring in a thoracic surgeon or a general surgeon when the primary surgeon isn't aware about it isn't going to be helpful, because I've seen a lot of complications where the general surgeon will get into the bowel several times, or the thoracic surgeon may not know. So I think I can tell you what it isn't, but what it is a full team for these cases that we want to advocate for centers of excellence that people can refer to. So that was one comment. The second one was, it was great that we all have material. This is, again, constructive feedback for all of us, but they would love practical templates or macros they can put into their EMR that says, this is the type of diet that we would recommend. Here are all your resources that we can cut and paste. So maybe as part of our guidelines as we look forward, we can actually give people cut and paste things they can put into their EMR and say, here, because I just gave a bunch of resources, they're going to have to look online. Can we give them stuff that's practical and they can get to? So that's, I think, really great feedback. And I think that was it. I want to thank everybody on the panel for coming out today on their own time. And I know that nobody here truly was given an honoraria or anything else. It was a work of passion. And we love the fact that we were able to spend time. All of you who stuck it through, all of you online who were there as well, thank you so much. And I hope you have a great day. Don't forget the evaluations and honest feedback that you can give us. And we look forward to perhaps doing this again in the future. Thank you so much.